Hello friends. So this is the first topic, that is gallbladder and biliary system, and we are starting uh, first class of this topic, that is anatomy of gallbladder and biliary system, as well as sonographic examination of the gallbladder and biliary system. So hope you have subscribed the this huge YouTube channel and press the bell icon so that you can get all the notification regarding our classes and videos. So let us start without any delay. So first topic is gallbladder and biliary system, and subtopic is anatomy of gallbladder and biliary system, as well as ultrasound examination of the same. So gallbladder is a pear-shaped organ lying in the inferior margin of the liver between the right and left lobe. The middle hepatic vein lies in the same anatomical plane. So that is the gallbladder in the same anatomical plane as that of the middle hepatic vein. And so it is used, may be used to locate the gallbladder fossa. If you are unable to search the gallbladder, then you can use the middle hepatic vein. Interlobar fissure is the third structure which separates the two hepatic lobes from the origin of the right portal vein to the gallbladder fossa. So, interlobar fissure is between the gallbladder fossa and the right portal vein. So, it is connecting structure of these two. This fissure has been seen up to 70% of the hepatic ultrasound studies, and it can be also used for the landmark for the searching of gallbladder fossa. So what are the division of the gallbladder? Gallbladder have three division: fundus, that is the most inferior and anterior portion of the blind end. So this is the fundus. This is the fundus. Then second is body, which is the mid portion between the neck and fundus. So this is the fundus, this is the neck, and the area between these is the body of the gallbladder. Then neck. Neck is the narrow tapering tube-like structure, which it is the most superior portion. It is smallest, that means narrowest transfer diameter, and it has fixed anatomic relationship between the main lobar fissure and the right portal vein. So this is the anatomy of the gallbladder. Now, what are the layer of the gallbladder wall? So it has in four layers. Outer serosal layer, which is the visceral peritoneum, formed by the visceral peritoneum. Then interior to that is the subserous layer, which is formed by connective tissue. Then inner to that is the muscular layer, which contract in response to hormone cholecystokinin, and inner epithelial layer, which is the mucosal layer. So four layers are there. Gallbladder, remember, gallbladder is in close relationship to the following structure, that is middle hepatic vein, interlobar fissure or major lobar fissure, and the right portal vein. Now, some anatomical consideration regarding the gallbladder, that spiral wall of the Hester is present in mainly in the cystic duct and sometime in the gallbladder neck, and it the prevent the collapse of the main cystic duct. Then second is the Hartmann pouch. It is present in the gallbladder neck. It is a infundibulum or pouch-like structure, which is the most common location of impaction of the calculus. So this is the MCQ, that which is the most common area or to locate where the calculus is impacted. That is the Hartmann pouch. Now, fundus of the gallbladder fold onto the body. This is known as the Phrygian cave. So these are the normal variant, normal structure which present in the gallbladder. Gallbladder is intraperitoneal organ and it is located in the gallbladder fossa on the posterior inferior portion of the right lobe of liver. It lies lateral to the infravena cava and anterior and medial to the right kidney. So it is lateral to the infravena cava and anterior and medial to the right kidney. Right kidney is present posterior to the gallbladder. It is lies posterior and inferior to the main lobar fissure. So it is posteriorly. The antilobar main lobar fissure present anteriorly and it lies posteriorly. It gallbladder neck lies most superior as we already discussed and fundus is posterior to the peritoneum and the transverse column. Now, gallbladder derives as an outpouching from the embryonic biliary outpouching from the embryonic biliary tree. The proximal portion of the pouch form the cystic duct and distal portion form the gallbladder. So, two parts are there. Proximal part of the pouch which form the cystic duct and distal portion which form the gallbladder. So within the cystic duct, there are small mucosal fold as we already discussed, that is spiral valve of the Hester, and they are occasionally identified on the sonography. During the initial development, the gallbladder lies as an intrahepatic portion and later it migrate to surface of the liver. And failure to migrate when it unable to come out of the hepatic parenchyma, it may lead to intrahepatic gallbladder or partially intrahepatic gallbladder. This is an important finding to recognize because it preclude. That means we cannot do laparoscopic surgery on the gallbladder if it is present intrahepatic because for that uh, we have to cut the liver. So that's why this is not a condition where the laparoscopic surgery can be performed. Conversely, the gallbladder may become fully enveloped in the visceral peritoneum and hanging from the mesentery line that extend from the liver. So this lead to increased mobility of the gallbladder and appear to be risk factor for the development of the torsion or valvulus of the gallbladder. So this is the intrahepatic gallbladder where you can see the liver is on, especially in transverse section, you may recognize better that it is surrounded all over by the liver parenchyma. Normally it is because it is on the surface of the liver, only one side is hepatic parenchyma present and other side is free. But here you can see the multiple gallstones are present and gallbladder is embedded into the hepatic parenchyma. So it is a intrahepatic gallbladder. And on the this CT scan, you can see that the gallbladder is a intrahepatic type. Now some anatomical variants, Hartmann pouch, we already discussed. Junction fold is a fold or septation of the gallbladder which is present at the junction of the neck and the body. Congenital anomalies are there like agenesis, which is the rare one. Duplication, where the partial or complete duplication may be there. Hypoplasia may be associated with the cystic fibrosis. Intrahepatic or ectopic location, we already discussed that it may be completely surrounded by the liver parenchyma, that is intrahepatic, and may herniate into the lesser sac. Then it is ectopic location. It may have multiple septated gallbladder, which is congenital malformation, and they mimic the ischemic pathology. Now, there is when the gallbladder is fully enveloped in the visceral parenchyma, it is may lead to torsion of the valvulus. We already location of the ectopic gallbladder are different type. So it may be suprahepatic, suprarenal, that is above the kidney, above the liver, anti-abdominal wall in the falciform ligament. So these are the location of the ectopic gallbladder. Now, septate gallbladder, when the gallbladder is composed of two compartments divided by the thin septa, it is known as septate gallbladder. It is usually not thick. If the thick septa is present, you should think of adenomyomatosis. Then duplication of gallbladder is often occur when the duplication of cystic duct may also present, and it may be diagnosed prenatally. The gallbladder supply for the is the from the cystic artery, which is a branch of the right hepatic artery, and less often from the gastroduodenal artery. So usually it's from the right hepatic artery give rise to cystic artery. Sometimes cystic artery may arise from the gastroduodenal artery. Normal gallbladder size or normal fasting adult gallbladder is measured approximately 8 to 12 centimeter in length, and it is 3 to 5 centimeter in diameter. The normal fasting pediatric gallbladder measure in infant is 1.5 to 3 centimeter, and in children it is 3 to 7 centimeter. So infant 1.5 to 3, in children 3 to 7, and in adult 8 to 12. What are the reason where you are not locate the may not locate the gallbladder? So, previous cholecystectomy, in case where the gallbladder has been removed, when there is a physiological contraction or postprandial gallbladder where recently empty after taking meals, may be due to the gallbladder duct fibrosis, may be due to the chronic cholecystitis, when gallbladder filled with air or stone completely fill the gallbladder, emphysematous cholecystitis, tumefactive sludge or hepatization of gallbladder where we are unable to see gallbladder clearly. Then ectopic location, it may not present in the normal site. The gallbladder may also may not be detected if there is agenesis of gallbladder, or the patient's body habitus is difficult. That means case of the obesity. So these are the reason for the non-visualization of the gallbladder. Sometimes the gallbladder wall is thickened in few cases. So non-inflammatory cause of gallbladder wall thickening are non-fasting condition, then ascites, cirrhosis, congestive heart failure, albuminemia, and the acute cohepatitis. In this condition, which are the non-inflammatory cause of the gallbladder wall thickening. Causes of diffuse gallbladder wall thickening are different. So, diffuse gallbladder wall thickening may be due to postprandial, acute cholecystitis, chronic cholecystitis, adenomyomatosis, hepatic dysfunction like hepatitis or cirrhosis, benign ascites, hypoalbuminemia, adds cholangiopathy, congestive heart failure, and gallbladder carcinoma. These are the conditions where the diffuse gallbladder wall thickening are may be there. Some focal causes of focal gallbladder wall thickening should you also know, that is gallbladder wall polyp, adenomyomatosis, gallbladder wall carcinoma, and adult gallstone. These may cause the focal gallbladder wall thickening. So these are the causes of gallbladder thickening. This is very important table, because question may be asked regarding this, and many question has been already asked in the previous CBT examination. So inflammatory condition, it may be primary and it may be secondary. So in primary, acute cholecystitis, chronic cholecystitis, and cholangitis may lead to gallbladder wall thickening. Then secondary causes of the gallbladder wall thickening are acute hepatitis, perforated duodenal ulcer, pancreatitis, and diverticulitis or colitis. In this condition, also inflammatory thickening of the gallbladder wall thickening is maybe there. Then some neoplastic condition like gallbladder adenocarcinoma and metastasis may lead to thickening of the gallbladder. Then some miscellaneous condition, adenomyomatosis and mural varicosities can cause the gallbladder wall thickening, and some generalized edematous condition like congestive heart failure, renal failure, end stage cirrhosis, and hypoalbuminemia may be associated with gallbladder wall thickening. Now we are review the anatomy of the biliary system. So function of biliary system, it transport the bile to the gallbladder through the bile duct, store and concentrate the bile in the gallbladder, and transport the bile through the bile duct to the duodenum. Function of gallbladder are concentrate the bile through the gallbladder or epithelium. It store the concentrated bile. It contract to release the bile when the bile hormone cholecystokinin is released into the blood stream, which is arise from the duodenum. Now, anatomy of the bile duct. So, bile system originate in the liver as a series of ductule coursing between the liver cell. The bile duct are subdivided into intrahepatic and extrahepatic duct. Intrahepatic duct follow the course of the portal vein and hepatic arterial branches. Main right and left hepatic duct lies empty to the corresponding portal venous trunk. Extrahepatic duct include the cystic and the common duct. Bile from the liver reaches the gallbladder through the hepatic and cystic duct. Then bile flows if the intraductal pressure is lower than the hepatic secretory pressure. So pressure difference by the affected by the activity of the sphincter of body and feeling a resorption of the bile in the gallbladder and the bile flow from the liver. So it is depend on the pressure changes by which the flow of the gallbladder bile is there. First is common hepatic duct, which is the main duct, where the right and left hepatic duct join near the level of the porta hepatis, forming the common hepatic duct. It located anterior to the proper hepatic artery, portal vein, and infravena cava, and it is located inferior to the right and left hepatic duct. Then next is the cystic duct, which drain the gallbladder. It connected to the gallbladder by the common hepatic duct to form the common bile duct. So it is having the variable configuration with mean length of approximately 4 centimeter. Post cholecystectomy, the cystic duct remnant measure 1 to 2 centimeter in length, that is half. It contains the spiral wall of the Hester. It courses posterior and inferiorly, merging with the CHD to form the common bile duct. So it connect to the common hepatic duct to form the common bile duct. So cystic duct form join with the CHD and form the common bile duct. It locate anterior to the main portal vein and the inferior to the common hepatic duct. It is usually not visualized on the ultrasound because it's a tiny duct. Then common bile duct. Common bile duct, the CSD is joined by the cystic duct to form the common bile duct. It courses inferiorly, joining the main pancreatic duct at the ampulla vater and enter the descending portion of the duodenum, that is part 2. It lies the anterior to the main portal vein and lateral to the proper hepatic artery. There are 4 portions of the common bile duct are there. So first is supraduodenal, which merge or form from the merge of the common hepatic duct with the vesical duct to external edge of a duodenum. Then there is second is the retroduodenal, from the external edge of the duodenum to the pancreatic head. Then pancreatic part, which passes behind the head of the pancreas or through its parenchyma, and intramural part, which passing in the depth of the wall of the duodenum. So it having the 4 parts: supraduodenal, which is not behind the duodenum. Second is retroduodenal, which is behind the duodenum. Third is pancreatic, which is in the pancreatic parenchyma or passes behind the head of the pancreas, and intramural, which in the deep in the wall of the duodenum. So this is the supraduodenal portion of the CBD. This yellow color is the CBD. This is the cystic duct, and this is the common hepatic duct. When we join the common bile duct, it's the supraduodenal portion, then the retroduodenal portion, then the pancreatic portion, then the intramural portion. Pancreatic portion in the head of the pancreas. So it's like this. And this is the stomach and this is the duodenum coming here. This is also better seen here. This is the duodenum. Here will be the stomach. This is the duodenum first part. This is the second part. So it is supraduodenal part, retroduodenal part, pancreatic part, and the intramural part. Size of the normal bile duct. Average intramural luminal diameter of the common hepatic duct is the 5 millimeter and should not exceed 6 millimeter in adult. Average intraluminal diameter of the common bile duct is 6 millimeter in diameter or less in the adult. So it upper limit is CHD and CBD is 6 millimeter. Starting at age 60, the CBD may increase in diameter by 1 millimeter per decade. So for 70, it is 7 millimeter. For 80, it's 8 millimeter like this. Post cholecystectomy patient may demonstrate a slight increase in diameter but should not exceed 10 millimeter. Average intraluminal diameter of the CBD is less than 4 millimeter in children, less than 2 millimeter in infant up to the 1 year, and less than 1 millimeter in the neonate. So you can remember 4, 2, and 1. The CBD will decrease in size or remain unchanged after a fatty meal. Then some definitions are there. Proximal or distal biliary. So proximal refer to the portion of the biliary that is closer to the proximity of the liver and hepatocyte. Distal refer to the caudal and related to the ampulla and the bowel. Central and peripheral. Central refer to the biliary duct which are close to the porta hepatis. Peripheral refer to the higher order branch of the intrahepatic biliary tree extending into the hepatic parenchyma. Is it confusing? No. So how you can easy? You remember P. P related to or near to the parenchyma. So peripheral and proximal are related to or near the hepatic parenchyma, and opposite are related to the or, bowel. So proximal, it is proximal. So P related to the hepatic parenchyma, so liver and hepatocyte. Similarly, peripheral related to the hepatic parenchyma. Okay. So this is the system. This is the central. Central is as far as the generations are concerned. His body is not out of reaction. And if you want our friends to believe this, that to support the fever, that particular. So proximal is in the parenchyma, peripheral is in the parenchyma. Central is related to the porta hepatis and distal is related to the bowel. So it's like this. Now, term branching order apply to the level of the division of bile duct starting from the common hepatic duct. First order branches are the right and left hepatic duct, and second order branches are to the respective division also known as secondary biliary radicals and so on. So most common branching pattern are like this, that is 50% cases. Branching pattern are like this. So right lobe, anterior segment 5 and 8 form the right anterior division. Then right lobe posterior segment, that is 6 to 7, is known as right posterior duct, and this is right anterior duct. Right anterior duct and right posterior duct form the join and form the right hepatic duct. Left lobe, second and third segment form the left hepatic duct, and also again is joined by fourth and first segment to form the left hepatic duct, second part, and both join to form the left hepatic duct. Then right hepatic duct and left hepatic duct form the common hepatic duct. Common hepatic duct joined by the cystic duct to form the common bile duct. Then common bile duct and parenchyma pancreatic duct open in the ampulla of Vater, and which open as a on the medial wall of the second portion of the duodenum. So this is the common pattern of the biliary system. So here this is bile flow is like this from the liver, biliary radicals, from the biliary radicals, uh, bile is formed and enter into the biliary radicals. From biliary radicals is goes in the right and left, right or the left hepatic duct. From where its common hepatic duct goes into the common hepatic duct, then goes into the cystic duct, then into gallbladder, then in the common bile duct, then ampulla vata, then through the sphincter of body, enter into the duodenum. So this is the normal pattern. These are the normal branching pattern. Right artery, right posterior, form the right hepatic duct. 3, 2, and 4 and 1 form the left hepatic duct, and they join to form the common hepatic duct. You should remember that the right and left hepatic duct, that is the first order branches of the common hepatic duct, are routinely seen on the sonography, and normal second order branches may also be visualized sometimes. The first order and second order are normally visualized by the ultrasound. However, visualization of third order or more branching order is abnormal, so higher is the abnormal. So if you see the higher order of the branching is there, then you should search for the obstruction lesion, obstructive lesion. Normal diameter first order and high order branches of the common hepatic duct is 2 millimeter or less. Most of the left hepatic and right hepatic duct are extrahepatic, and along with the common hepatic duct form the hilar or central portion of the biliary tree at the porta hepatis. Spectral and color Doppler ultrasound are often needed to distinguish hepatic artery from the duct. Through duct tend to be straight, whereas arteries are tortuous. Some variation are there. The common normal variant of the biliary branching pattern is due to variability in insertion of the right posterior duct. The right posterior duct is joined at different level, and which they form the variation of the branching pattern of the biliary tree. So most common anomaly or variant in the aberrant insertion that join to the left hepatic duct. So this is the normal, that the right posterior duct join the right anteduct to form the short hepatic duct. This is the normal variation. This is the normal pattern. So sometimes it may join at the junction of the right and left hepatic duct. This is known as trifurcate pattern, trifurcation pattern. This is the 8% cases of the normal variation. Most common variant is that if the RPD extend more to the left than the usual and it can join the left hepatic duct, this is the most common variant, that is the 13%. This is the aberrant right posterior duct, where this transfer image showing that the right posterior duct is entering into the left hepatic duct. This is the most common anomalies of the biliary tree. Then if the RPD extend at a caudal medial direction, it can join the common hepatic duct or common bile duct. This is the 5% cases. Normal caliber, we already discussed, up to CSD and CBD 6 millimeter or less. In the post-cholecystectomy patient and older patient, up to 10 millimeter. We can add 1 millimeter per decade of the 60. After 60, we can add 1 millimeter per decade. So great majority of diameter are under 7 millimeter. And if ductal diameter of 7 millimeter or greater in a younger patient, we should prompt further investigation such as correlation with the serum level or cholestatic fever enzyme. The variation of the insertion of the cystic duct into the bile duct, which is the coid variable. Cystic duct may join the bile duct along the lateral portion, posterior portion border or the medial border, and it may also run parallel course to the duct and insert into the lower one third of the duct closer to the ampulla veter. So it may join differently. So this is the cystic duct. So cystic ducts may join common hepatic duct or may join directly in the lower insertion may be there. So or it in the common sheet parallel it run may parallel and like this. So different are there. Now what are the sonographic appearance of the different ducts and branching pattern? So normally intrahepatic bile duct are in anechoic non-vascular tubular structure coursing within the hepatic parenchyma. They have a smooth hyperechoic wall. Normal intraluminal diameter of the common hepatic duct should be there. Right and left hepatic bile duct generally lies anterior to the corresponding portal vein. Intrahepatic bile duct are not usually routinely visualized on the ultrasound. Normal extrahepatic bile duct, normal pattern is longitudinal plane, anechoic non-vascular tubular structure anterior to the main portal vein and the proper hepatic artery. So in longitudinal plane, it is anterior to the main portal vein and the proper hepatic artery. It is having the smooth hyperechoic wall and normal intraluminal diameter of the CBD. Then transfer pattern plane, the anechoic non-vascular tubular structure anterior to the main portal vein and lateral to the proper hepatic artery. So in transfer plane, it is lateral to the proper hepatic artery and smooth hyperechoic wall. Abnormal intrahepatic and extrahepatic duct will show that abnormal intraluminal diameter of the common hepatic or common bile duct that is more than 6 millimeter or more than 10 millimeter respectively in the normal patient and the post polycystectomy adult patient. Then thick irregular non-parallel wall will be seen in case of the abnormal duct. Now, these we have already discussed. Now, next is the sonographic appearance of the gallbladder and biliary system. So, examination technique and protocol and image optimization. So, indication of the ultrasound examination of the biliary system is right upper quadrant pain, which may radiate to the upper back and chest. Increase in the liver function test, nausea, vomiting, intolerance to the fatty food, postprandial, positive Murphy sign, and jaundice. These are the indication for the ultrasound examination of the gallbladder system and the biliary system. Preparation to obtain the optimal evaluation, the patient should be fasted before the ultrasound examination. So you can remember adult 6 to 8 hours, for children 6 hours, infant 4-hour fasting is required. In case of the post cholecystectomy patient, no preparation is required because gallbladder is not there. Although fasting is still recommended to decrease the amount of bowel gas in the gastrointestinal tract. In case of emergency, gallbladder study can still be performed. Transducer selection for adult. You have to use the highest frequency possible to obtain the optimal resolution penetration depth. So adult 3 to 5 megahertz transducer is needed, and for small adult or the children 5 to 7 megahertz, that is high frequency is needed. For the obese patient, low frequency that is 2 megahertz may be required. So wide field of vision curvilinear transducer is used, and sector and the vector transducer may have small footprint, which may be helpful in case of the intercostal imaging. Position of patient is usually begin with the patient in the supine position. Left lateral decubitus, left posterior oblique, and upright position may be helpful to evaluate the mobility of the gallbladder stone as well as the elevating the overlying bowel gases. Ingestion of the 500 ml of the water and placing the patient in the reverse cantilever can aid in visualization of the distal common bile duct and the head of the pancreas. Examination protocol, systemic approach to the sagittal and transverse plane for the carefully examining the and imaging all the portion of the gallbladder and biliary tract is including neck, body, fundus of the gallbladder. Intra and extra hepatic biliary tree to include the distal common bile duct is needed. Measurement of the thickness of the gallbladder wall is done. Measure the anteposterior intraliminal diameter of the common hepatic and common bile duct. When encountered, document the mobility of the echogenic focus in the lumen or of the gallbladder with change in the patient position is needed. Then abnormality should be documented and when applicable measured into two imaging plane. Color and spectral Doppler evaluation of the abnormality should be included and documented. Due to association of the pancreas and liver within the biliary tree, sagittal transfer image of these structures should be included in the gallbladder examination along with flow, type and direction of the main portal vein. Image optimization is place the gain setting to display normal liver parenchyma as a median shade of the gray and normal gallbladder as a anechoic ovoid structure. Focal zone at place at or below the area of the interest. Use of the multifocal focal zone to increase the detail resolution and decrease the temporal resolution. Sufficient imaging depth to visualize the structure immediately posterior to the area of the interest. Harmonic image should be used to evaluate and document the biliary tree. Decreasing the systemic compression, that the dynamic range should be decreased to use the to reduce the artifactual echoes within the gallbladder lumen, main portal vein, and biliary duct. Special compounding can be used to improve the visualization of structure posterior to the highly attenuating structure. Doppler imaging study should be adjusted for a slow flow rate. Use of the deep inspiration may improve visualization of the gallbladder and common bile duct. Use of the multiple patient position may resolve overlying blood gases. In imaging, these are the limitations that incomplete patient preparation, gastrointestinal gas and obesity is the limitation. Sonographic appearance we already discussed. Now, these are the images we will obtain during the sonographic examination. This is the longitudinal image of the gallbladder. Whole we have to see by fanning of the transducer to see the whole lumen of the gallbladder. We should document and save the image like this, where the whole of the lumen is visible optimally. Then we take the transverse section, short axis view, and see the gallbladder wall. Measure on the anti-gallbladder wall in the short axis dimension direction section should be done. We sieve the probe. Then we see the common bile duct and common hepatic duct and the portal vein and the hepatic artery. This is the area of the porta hepatis. This is also area of the porta hepatis. We can put the color to evaluate the portal vein and the also the hepatic artery and also to differentiate the common bile duct with the portal vein. This is the again portal vein, hepatic artery, and common bile duct. This is the Mickey Mouse sign, where the face is the portal vein, then left ear is the hepatic artery, and right ear is the common bile duct. We can use the contrast imaging to recognize the biliary pattern. This is the porta hepatis, again common bile duct, hepatic artery, and the portal vein. This is the video of the gallbladder scanning, by which you can recognize the how the scanning of the gallbladder is done.
Hello friends, so we are now scanning the gallbladder of the patient. This is my patient. Hello friends, so we are that is hello friends, so we are now scanning the gallbladder. Hello friends, so we are now scanning that is extrahepatic biliary tree. We have to put the probe on the same position and try to locate. We are now scanning the gallbladder of the patient. This is my patient. We have to keep the probe at the right medial angle of rib. It is here. You have to keep perpendicular to it, perpendicular and inferior to it, and then we have to scan here. So now the gallbladder has been appeared on the screen. We have to move side testing movement, and we can achieve the long axis of the gallbladder. सांस खींचो. Ask the patient to take deep breath, and the gallbladder will appear in its longitudinal section. We have to make the movement like this, scanning and fanning the whole of the gallbladder up to the fundus and beyond it. So we have to see any abnormality like thickening of the gallbladder wall or any echogenic foci in the gallbladder lumen like this. सांस खींचो. We have to scan beyond the gallbladder. We have to scan whole of the gallbladder thoroughly. सांस खींचो. Like this. Now, second step is to move perpendicular to the previous one, that is this, like this. Now the gallbladder is appear in its long axis to short axis, that is here. Now, after achieving the axial plane of the gallbladder, you have to move the probe so that you can scan the whole of the lumen of the gallbladder in its axial or transverse plane, like this. सांस खींचो. You have to go reach up to the fundus of the gallbladder and beyond it, so that no abnormality missed in the lumen of the gallbladder. Pause करना.
That was the gallbladder scanning. Now we will move to the biliary tree examination.
That is extrahepatic. That is extrahepatic biliary tree. We have to probe on the same position and try to relocate the gallbladder lumen, that is here. Then पेट खुला के बाहर की तरफ. Then we have to locate the neck of the gallbladder and its relation to right branch of portal vein, that is, and then portal vein. So we have locate the portal vein. This is सांस पेट बाहर की तरफ खुला है. Portal vein. This is the portal vein, and just anterior to it is the common bile duct. This is the common bile duct. We can zoom it and see the थोड़ा सांस रोक लेना यार, and see the lumen of common bile duct. Any abnormality in it, we have to trace it up to the duodenum. Here the duodenum appear, and this part is posterior to the duodenum, retroduodenal part. This part is posterior to the duodenum. You can see that CBD in long axis, and at the same level portal vein is in short axis. Now, as we have to move slightly other side of the duodenum to get the distal part. So this is the proximal part of common bile duct, and it is going behind the duodenum. This is duodenum. So this posterior part is posterior to the duodenum part is obscured. So we have to go toward the other side, and we can relocate the distal part of the common bile duct. This is the common bile duct. So it was here initially, then I have to go like this and then relocate the distal portion of the common bile duct. Okay. Now again we can relocate the distal part and move the probe to the 90 degree, so that the distal part which is in the head of the pancreas is now in axial section. This is the inferior part of the head of the pancreas, and the common bile duct is in the axial plane. सांस अंदर खींच के रोक ले थोड़ी देर, फिर छोड़ दे. This one, and then we can move the we can go toward the liver to see its axial section. This is how we can access the common bile duct in both section. Now we have to take the measurement of common bile duct. We have to measure from inner to inner border. This is like this, and it is 4.3 centimeter. If there is confusion whether it is common bile duct or portal vein, we can put the color Doppler. The blood flow will be appear in the portal vein and not in the common bile duct. So this is the portal vein and this is the CBD. बंद कर दे.
Now few MCQs. Small protrusion near the neck of the gallbladder describe. Yes, it is a Hartmann pouch. It is a small posterior pouch near the neck of the gallbladder. And junction fold is a fold or septation near the gallbladder neck. Small septation located between the neck and body of the gallbladder best describe a. It is a junctional fold. All of the following are sources of the diffuse gallbladder wall thickening, except. So diffuse wall thickening may be caused by all except the malignant ascites. It does not cause thickening of the gallbladder. All of the following are sources of the diffuse gallbladder wall thickening except. So all will cause diffuse gallbladder, that is benign ascites, hepatitis, congestion, heart failure, except the gallbladder polyp, which because gallbladder polyp will cause focal gallbladder wall thickening. Anomalous gallbladder location may be due to. It may be due to all, that is elongation of cystic duct, absence of the supporting mesentery, and herniation through the foramen of Winslow. All of the bulbous region of the neck of the gallbladder where the gallstone get impacted is known as. Yes, it is Hartmann pouch. By which imaging modality gallbladder can be best visualized? Yes, best technique is the harmonic imaging. Common cause of the distension of the gallbladder without wall thickening. All are except. So it is distension of gallbladder without wall thickening is due to hepatitis and postprandial. Cystic artery can arise from the following arteries except. So it can be arise by all except the right gastric artery. It does not arise from the right gastric artery, but It can have gastroduodenal, retroduodenal artery, middle hepatic artery, and left hepatic artery. Not by the right gastric artery. Diffuse thickened gallbladder wall thickening is seen in all except, again, it's a malignant ascites. During GB sonography, you notice echogenic foci within it but do not detect posterior shadowing. What changes below will improve the detection of the stone shadowing? Yes, it is. You have to increase the frequency and transducer focusing. Failure to visualize gallbladder on ultrasound may be due to, it may be all cholecystectomy, fibrous gallbladder due to the chronic cholecystitis agenesis. All. Fetal gallbladder can be seen earlier in most of the fetus by, yes, it is 14 to 16 week. Gallbladder derive the blood supply from both cystic artery and the gastroduodenal artery. Gallbladder neck is related to, it is right branch of the portal vein. Gallbladder neck is related to right branch of the portal vein. Gallbladder anatomic variants pick the false statement. Which is the false? Wall of the external in the gallbladder neck. It is present in the cystic duct. Though sometimes it may be there. Gallbladder wall thickening observed in which condition? So it is all of the above. All may associate acute cholecystitis, chronic cholecystitis, liver cirrhosis, hyperplastic cholecystitis, and gallbladder cancer. All may be associated with the gallbladder wall thickening. Gallbladder dilated if it is round and not ovoid and transfer diameter is more than, it is 4 centimeter. Transfer diameter 4 centimeter. Gallbladder thickening is seen in all of the following except, it is fatty liver. In this, but otherwise ascites, hepatitis, hypoalbuminemia, it may be thickened. Generalized gallbladder wall edema may be seen in all except polyp. In polyp, there is localized focal thickening. Failure to gallbladder wall bladder on the ultrasound may be due to all cholecystectomy, fibrous gallbladder, and agenesis. So that is all. That is all. This was the first topic to revise the gallbladder, sonographic anatomy, and sonographic examination. Thank you all. We will meet in the next video soon. Don't forget to subscribe so that you can get the notification and information about the next videos. Thank you.